Dear all, it's my pleasure to speak about the pharmacokinetics of amikacin and vancomycin in the treatment of endophthalmitis. And I know it's a little bit tough subject, but it's an essential and very important subject to send message for the postgraduate ophthalmology doctors. I'd like to thank Dr. Shayma Al-Basuni and Dr. Mohammed Al-Masri for helping me in the preparation of this presentation. So we know endophthalmitis is the nightmare of ophthalmic surgeons, and it's an intraocular infection, whether it involves the vitreous and or the aqueous humor. And the common cause is usually post-surgical or post-traumatic or post-endogenous infection. And the importance of prompt treatment to preserve vision is vital for all of us. And of course, all of us, we don't like to see cases of endophthalmitis, but any high volume surgeon definitely passed by this nightmare at a time. So, where the common pathogens in endophthalmitis are gram-positive bacteria like the Staphylococcus aureus or the Streptococci, or gram-negative bacteria like the Pseudomonas aeruginosa, or the fungal organisms like the endogenous Candida albicans or and Aspergillus, or exogenous like Aspergillus and Fusarium, which are the most common. To have an overview about the amikacin and vancomycin, amikacin is an aminoglycoside and vancomycin is a glycopeptide. The mechanism of action of aminoglycosides is to inhibit the bacterial protein synthesis by binding to the 30S ribosomal subunit. If this is the gram-positive, this is gram-negative, the amikacin works on the gram-negative organism by inhibiting the synthesis of the by binding to the 30S ribosomal subunit, and the glycopeptide inhibits the bacterial cell wall synthesis by binding to DLA and DLA precursors. What are these DLA precursors? They are simply ATP-dependent enzymes, and they found that the resistance of this vancomycin only from genes that contain these DNA ATP-dependent enzymes. So vancomycin, in spite of being more than 40 years in the market, but it can kill the gram-positive bacteria depending on the 3 dipeptide ligase genes, which attack the DLA and the DLA precursors. Again, the spectrum of activity, as you said, amikacin works on gram-negative bacteria, while vancomycin works on gram-positive bacteria, including the MRSA. So in endophthalmitis, it is effective against these bacteria. What is the pharmacokinetics? Pharmacokinetics could be summarized in the 5 subtitles on your left-hand side, which are the absorption of the drug, the distribution of the drug, the metabolism of the drug, elimination of the half-life, and the dose of the drug. Absorption of amikacin is poor in oral absorption, so it is either administered intravitreally or intravenously. And also, vancomycin is poor in systemic absorption, and it is absorbed either intravitreally or intravenously. The distribution, it is limited systemic distribution, but it is good intraocular penetration. So if it is inside the eye, it has very good effect on gram-negative bacteria. And the same for the vancomycin with limited systemic distribution and good intraocular penetration for intravitreal injection. It's not metabolized and excreted as it is in the urine. That's why the side effects is the nephrotoxicity if it is administered intravenously, and the same like the vancomycin, not metabolized and excreted by the kidneys. The elimination half-life time is 2 to 3 hours systemically, which means if we inject intravenous amikacin, it will be eliminated within 2 to 3 hours. And it is definitely longer inside the ocular tissue, as you are going to see in the next few slides. And the elimination time for vancomycin is a little bit longer, as it takes about 4 to 6 hours to be eliminated. And again, it is longer inside the vitreous. The intravitreal dose of the vancomycin of the amikacin is 200 to 400 micrograms, while the intravitreal dose of the amikacin is 1 milligram. So If you compare the pharmacokinetics of both drugs, amikacin has an intravitreal half-life time of 20 to 30 hours peak. That's why just one injection could be enough to eliminate the infection. And the intravitreal half-life time of vancomycin is from 48 to 72 hours. So it reaches up to 3 days inside the vitreous in order to be eliminated. So it has a higher concentration in the vitreous due to the slower clearance. The dosing strategies in endophthalmitis, amikacin is given as a single intravitreal injection, possibly followed by systemic therapy. And the vancomycin is used in combination with other antibiotics for broad spectrum coverage. And the frequency depends on the clinical response and intraocular drug clearance, which means that we can repeat the injection if the patient still has the same problem but improved a little bit. But the potential side effect and the toxicity of the drugs, both of them may result in nephrotoxicity, ototoxicity, retinal toxicity at high intravitreal dosage, and the vancomycin may cause some ocular irritation and rare retinal toxicity at the therapeutic doses. So to have retinal toxicity from amikacin, you need high intravitreal doses. But to have retinal toxicity from vancomycin, it could be from the therapeutic doses. So it is not advised to give it routinely in all cases of cataract surgery. This is the most important slide in the presentation. Bacteria double every 20 minutes. So if you see patient with endophthalmitis and you decided to do the surgery for him, every 20 minutes there is doubling of the bacteria. If it is 1,000 now, after 20 minutes it will be 2,000. After 20 minutes it will be 4,000, 8,000, 16,000, 32,000. So it doubles every 20 minutes. So the patient loses his vision if you postpone the surgery even for an hour. So once you see endophthalmitis, immediate action should be taken depending on what you are going to see. The endophthalmitis vitrectomy study group said that if the patient has hand motion or better, immediate intravitreal injection should be done. If it reaches perception of light, do vitrectomy. But nowadays, the earlier, the better. Early vitrectomy plus intravitreal antibiotics are the essential backbone for the good result. The earlier, the better. So let's just to discuss more case studies about clinical evidence medicine about what we are saying about the amikacin and vancomycin. These two papers had been published in the American Journal of Ophthalmology in 1993 and one of vancomycin in the retina in 1995. And Dr. Ashraf Sha'rawi was with me in this research about the effect of amikacin and vancomycin on the its half-life time in the vitreous of rabbits. And this had been published in the American Journal of Ophthalmology, and this had been published in the retina. And to take the first study about the effect of amikacin in the vitreous, we found that in vitro, amikacin is active against broad-spectrum or gram-negative and gram-positive organisms, many of which are resistant to other aminoglycosides, including gentamicin, tobramycin, and kanamycin. We have a paper about amikacin and gentamicin comparison between the intravenous and intravitreal injection, and we found that there is no effect of the intravenous injection, and amikacin is better than gentamicin in the intravitreal injection. Additional studies have shown that amikacin combined with beta-lactam antibiotics, and just to know that beta-lactam antibiotics are the first antibiotics like the penicillin, which contains a beta-lactam ring, and acts synergistically against many clinically important gram-negative organisms. It is administered by direct intravitreal injection of the maximum non-toxic dose of antibiotic, providing intraocular levels much higher than can be obtained by systemic administration. And amikacin has been recently, that's in 1993, which is since 32 years now, recommended as the aminoglycoside of choice in treatment of endophthalmitis. And that is very strange. One drug. Now, at 1993, it was 20 years before that amikacin was discovered. 50 years age drug resists the bacteria, and even the MRSA are killed with amikacin and vancomycin. And this is a mercy from God that we have still one antibiotic that still can kill the bacteria in spite of being the resistance that arises every day. Higher initial doses are thus possible for amikacin, offsetting to a degree the fact that its activity against many gram-negative organisms in vivo is less than that of gentamicin. Intravitreal injection of 400 microgram of amikacin in the midvitreous cavity was subsequently performed in all eyes under indicted ophthalmoscopic observation 24 hours after bacterial injection. And just to know how can we prepare the amikacin, simply we withdraw 1.6 milli from the vial, which contains 250 milligram per milli, which means 500 milligram to milli, which means 400 milligram in the 1.6 milli, and continue to 10 millimeter in the syringe sodium chloride. Then take just 1 milli and discard the rest of the solution, and transfer the solution from the syringe into a sterile gallipot using 1 milli syringe, draw 0.1 milli, which equals to 0.4 milligram. We found that in the half-life type of amikacin in the phakic non-inflamed eyes was 25.5 hours. And in aphakic non-inflamed eyes, it had been dropped to 14.3 hours, which means that the amikacin was cleared after 14 hours from the vitreous of aphakic eyes and after 25 hours from the vitreous of phakic eyes. And this is because simply when we remove the lens, there is more space, so the washout of the amikacin is higher in the vitreous, which means that the half-life time had been dropped to the half after injection. The longest half-life time of amikacin in phakic non-inflamed eye, the shortest in the aphakic inflamed eyes or controlled aphakic vitrectomized eyes. Inflamed aphakic and inflamed vitrectomized had the shortest lifetime, even they may reach up to less than the MIC or the minimum inhibitory concentration of the drug. The second study was about the vancomycin that I said before. It was my honor to be with Dr. Ashraf Sharawi that we did it and published in Retina in 1995. And again, vancomycin, as we said, is the drug of choice for injection for gram-positive endophthalmitis or gram-positive organisms. And we simply had three groups like that of amikacin, aphakic, and aphakic vitrectomized rabbit's eye. One eye is controlled and the other eye is inflamed or we induced endophthalmitis in these cases. And after 24 hours, we injected the vancomycin. And again, we found that the clearance of the vancomycin exactly like that of the amikacin. In aphakic vitrectomized eyes, the half-life time was 9 hours. In aphakic eyes, half-life time was 8.9 hours. In the phakic eyes, it was 25.1 hours. And the inflammation increased the rate of elimination of vancomycin only in the aphakic group. Again, how to prepare the vancomycin? Simply, the vial contains 500 milligram, and withdraw the vial with 8 milli of saline, and withdraw the entire contents in a syringe, and place 1 milli of the solution in 5 milli syringe, and add 4 milli saline, so the total of 5 milli, and the result of solution concentration is 10 milligram per milli or 1 milligram per 0.1 milliliter, and injected intravitreally. Combination therapy, the rationale, broad spectrum coverage, gram-negative and gram-positive organisms. The challenges are the safety, doses, and minimizing the toxicity. The pharmacokinetics challenges are poor systemic penetration of antibiotics in the vitreous, importance of intravitreal administration, balancing the efficacy and toxicity with precise dosing. The future directions is for advances in the drug delivery with sustained release formulations and nanoparticles or new antibiotics under investigation for intraocular infection. And to sum up, the key points, amikacin and vancomycin pharmacokinetics differ, and both are crucial in treating endophthalmitis, and precise dosing and administration are the keys of success. These are the references, and thank you so much.